So that's a nice example. You can see some fibrosis here over the disc. But when you do fluorescein angiogram on optos, you can clearly see that the vascular supply is limited up till here. All that periphery, there is a retinal ischemia, which you may not pick it up by doing the normal fluorescein angiogram. So that's again a very nice broader field of view. You can see the peripheral retinal ischemia. And that's 23 millimeter longitudinal. It's showing its transverse area, it's showing up. So in one go. So that's giving the view. So if you're looking for the fractional, any issue, you may not be seeing very fine details, but significant details you can go and see in periphery. Coming to my last investigation, B-scan ultrasound. When would you like to do it? Mostly when you have got a media opacity like cataract. You can't see, you want to see what's happening behind that, or vitreous hemorrhage, significant vitreous hemorrhage. You want to look for that. Is it just a vitreous hemorrhage, or is there any other surprise for you, like retinal detachment? And like tabletop retinal detachments can be there as well. And it's really important. Sometimes you lower your guard, because recently I heard one patient with vitreous hemorrhage, one of my colleagues gave injections and she referred that to me, patient for non-resolving vitreous hemorrhage. And I said, okay, leave the P-scan. And as I went in, I did remove the vitreous, all retina was detached there. And there was basically posterior break there. So mostly you are prepared about, but sometimes if you require any extra thing, a sort of thing, you would be surprised. You would say, oh, I should have known about that, what I'm going to do now in this case. So it's really important. So in conclusions, I think investigations are really important in managing diabetic retinopathy. And you need to have, in a good retina practice, you need to have all these gadgets with you so that you can diagnose the patient and manage them properly. And invasive and non-invasive, both investigations are available. Initially, you start with the non-invasive one, but where you require invasive, I think it's really important to do them, to diagnose the patient. And especially if the patient is not responding, please revisit your diagnosis. You need to look back. You need to see either you're managing the patient properly or you're missing something. So you may be managing your patient in better that way. Thank you very much. Thank you.
Thank you very much. If there are any questions.
Professor Daud Saab, Professor Sanaullah Jan, Dr. Mazhar Ishaq, and dear colleagues, thank you very much for your kind invitation, and it's always a pleasure to come to Peshawar. So I'm going to talk about the investigations, what different investigations that we can do related to diabetic retinopathy. So I think a lot have been told by Professor Amer, and it's really alarming that what sort of a situation we are going to face now and even in the future. So it is a leading cause of the blindness in work age adults. So it's really important the people who are in working class, they are getting affected. And it also leads to significant cause of morbidity and mortality in diabetic population. An earlier thing, what you can observe is microvascular and macrovascular changes within the eye. And especially you can notice these changes in arterioles, venules, you can see the enlargement of foveal avascular zone and shape alteration of that zone. So it's really important. So why it's important to investigate diabetic retinopathy? Why can't we just treat it directly? I think more important things are because screening is really important. As Professor Amer already mentioned, that if we won't know who are at the risk of developing diabetic retinopathy, it would be very difficult to treat them. And in the West, they're really clever, and they have come up with the screening programs, especially I have been trained in UK, very excellent training program, and that will lead to so much difference that not significant diabetic retinopathy we were seeing there. So I was in Glasgow, which has higher risk of diabetes prevalence, but coming to the surgical complications related to diabetes, very few people we were operating there. Since I've come to Pakistan, my major chunk of surgery is related to the diabetic-related problems. Second thing important is the diagnosis. You want to make the diagnosis, either you are treating maculopathy, you are treating proliferative diabetic retinopathy, it's really important. Third important thing is the response to the treatment. Are the patients which we are treating, are they getting any response or not? If we won't do investigations, we are not going to find it. Fourthly, I think it's important to revisit the diagnosis. Sometime we are treating the patients, we are not achieving the target what we are aiming for, and actually we need to revisit diagnosis. And then again investigations come up, and you can see that either the problem you're thinking, was it the right thing, or is it something else happening there? Lastly, but again important, monitoring for the long term. Once you have treated the patient, for the long term monitoring, I think it's still important to do the investigation. So these are few investigations which I'm going to talk about. So color fundal photos. So people would say, why a person is coming to the eye specialist, they can just have a look and they can just make the diagnosis accordingly. But here the screening part comes. So there are, in the West, they have got the screening center, the reading centers where the patient comes and they just get the photos of their eye. And those photos are judged by reading experts. They look at, and if they suspect any diabetic retinopathy, they see hemorrhages, they see hard exudates, and they feel that it needs to be referred, there are certain criteria, they will send over the patient to the ophthalmologist. So not every patient needs to be seen by ophthalmologist. So logistics are really important, so screening programs are really important regarding that. Other important thing is even in India and some other countries, they have got like mobile guys which go and take the photographs, and smartphones are really important, that really help. So coming to the OCT, optical coherence tomograph scan, which is basically infrared light that penetrates the eye and it gives you details in the microns. So it has got very good depth perception there. So that's a typical OCT which we see, and it actually gives the same details which we were getting from the histological slides of eyes taking out. The same things are now we are getting just within a few seconds. So we can see all the layers. So starting from there, nerve fiber layer, going up to retinal pigment epithelium, we can see all the 10 layers of the retina, which is marvelous. And even we can see the vitreous, we can see the choroid, we can see choriocapillaris, large layers of the choroid, which is a real great achievement. And that's from the Plex Elite, which is one of the Zeiss new OCT. It's really great. It gives the broader view, so we can get the broader details just in one go with this OCT. So there are different types of the OCTs. Initially we started with the time domain, then spectral domain came up, and now swept source, which has got a better resolution, better penetration. So if we look at the fundal photograph, if you're seeing the patient, you may not notice the things over the macula. You may think that patient is not having any problem, but when you check the vision, you see vision is reduced. And when you do the OCT, you can see that there is a large intraretinal cyst formed there, just subfoveally, and that's reducing the vision. Similarly here, you can see large cystic spaces here and causing intraretinal edema there. So yes, clinically you can see it, but you can miss it. So I think it's always keep in mind that you can do the OCT and you can make your diagnosis. So that's a very nice image where you can see that there is a vitreous posterior highlight face is attached here, so it's a vitreomacular traction there. Then you can see is that there are intraretinal edematous spaces here. You can see the hyperreflective foci, which are hard exudates, and here you can see the neurosensory retinal detachment. So the sensory part of the retina is lifted up. So it's really important to know, because in this patient, if I'm just giving the injections, that patient may not improve. That patient may require vitrectomy and releasing of that traction and finally doing ILM peel. Again, you need to know the structures of the retina, which is really important when you're treating it. So that one nicely shows the inner retinal structures. So here we can define the intraretinal structures. We can see all ganglion cell complex. We can see IPL, inner plexiform layer, and nuclear layer. So 3 layers, we are clearly seeing it. But if you look on the right side, it's disrupted here. So in this case, prognosis will not be great. So you're treating the patient, but at least you can tell the patient how much vision they are going to get it. So that's similarly, outer retinal structures are very important as well. So inner segment, outer segment junctions are really important. External limiting membrane is really important. Here you can see that all intact. So this patient has got a very good prognosis. Here, IS-OS junction is disrupted. And here, even ELM is disrupted as well. So very bad prognosis for this patient. So here you can see that the inner retinal structures are really disorganized. Large cyst has formed, but you can't see much detail. So that patient may be more likely that the vision will not improve much in spite of the treatment. So good baseline predictors, subretinal fluid, intraretinal cyst, or vitreal macular adhesions, you can have a better prognosis when you're treating these patients. And poor baseline, as I mentioned earlier, inner retinal layers. So if they are disrupted or disorganized, or disruption of the outer and inner photoreceptors, that in that case, prognosis will be poor. Similarly, you look at the choroid as well. If subfoveal center part of the retina choroid is quite thin, that means that their functionality will not be good. So coming to the proliferative diabetic retinopathy, again, this is a very good investigation, OCT. You can see here that there is a new vascularization over the disc. Even on the OCT, you can clearly see that this area on the posterior highlight face is lifted up, the new vessels are developed there. So in some patients, you even treat it, but still they keep on bleeding. The reason being that there is traction over the vessels, which is causing the bleeding, and they can have recurrent bleed. So in those cases, you need to treat them with the surgery, with the vitrectomy. So again, you can't rely totally on the OCT. If you look up, you may say, oh, it's perfectly all right, there is no problem at all. But if you look at the wide field fluorescent angiogram, you're seeing these leaking area, and there are some peripheral area where it's the retinal ischemia. So you have to correlate your findings. You are using OCT, you are looking at the fundal photograph, and you're keeping other investigations handy as well. So just few examples. I don't know much you're seeing or not. Is it coming up anything you or very poor, or it's a hazy view here anyway in this case. So, but you may see here the vessels, you are seeing some fibrosis, but you may not make up much things until I show you this one. So that's basically the fovea is lifted up. The patient has got central retinal detachment, the whole central part of the lifted up toward the disc, and patient is having significant reduction of the vision. That's another patient. You can see some fibrosis here, above there, above and over the arcade here. Here you may see in red free, this is the fibrosis, this here. But when we do OCT, we can clearly see that the macula, how bad it is. So there is quite a significant fibrosis, which is lifting up the retina significantly. So in these cases, if you keep on injecting, it's not going to make any difference. The fibrosis will keep on increasing, and the patient will have more problem. So this is the, one of the, my patient who was a doctor, who came to me with significant reduction of the vision. Vision was counter finger. So that's a disc. So that's a left eye, quite a significant fibrosis you are noticing here. But you may say that the macula may be all right, but it's not. You can see it's all detached. So that's all the macular area which is detached. And that's the reason that the vision was significantly reduced. So he had later had surgery, and everything resolved, and vision has improved to some extent. So that's the other eye of this patient. So cottonwood spot we can see. Here you can see more significantly, patient has intraretinal edema and proliferative diabetic retinopathy that was treated with PRP and injections. So that's another patient. So you may see the fibrosis over the disc and over the macula, and you may not notice that how much difference it's going to make. So it's lifting up significantly over the macula, this fibrosis, and causing the problem, which means that quickly surgery patient will have the better prognosis, they are going to get it. Similarly here, the large fibrovascular membrane covering the whole macula. There are some hemorrhages as well, pre-retinal. And if you look here, basically that fibrosis is lifting up the macula completely and causing the problem. So that's another patient with the fibrosis you can see here. And this is the fovea basically. The patient's fovea is lifted so much off. If I wouldn't have done the OCT, I will not know the exact picture of that. So there was a video which will not play here, so I'll move on to next. So this is another patient, only eye patient, diabetic patient, who had this sort of the picture. Vision was significantly distorted and came down. So what was happening because of that, the traction, he's developing lamellar hole, these receptors are getting blocked. We are seeing the outer retinal structures here. That's why the vision is a bit better, but he's having significant distortion. And even in the multiple section, you can see it here.